Hello, everyone. It's another podcast, and today I'm here with Kristin Higgins, who's the Chief Clinical Officer at City of Hope Atlanta and a professor of radiation oncology. And today we're going to chat a little bit about small cell lung cancer. Kristin, why don't you tell us a little bit about yourself?
Sure. I'm a thoracic radiation oncologist. I recently became the Chief Clinical Officer at City of Hope Atlanta. Prior to that, I was at Emory for about 13 years. Most recently at Emory, I served as Vice Chair for Clinical Research and leader of our lung cancer program. And recently just took this role as an opportunity to expand my leadership and really sort of grow in the roles that I was taking on. And it's been really fun so far.
Yeah, I've been watching your career for a while, and I got to say, I'm a really big fan.
Oh, thank you.
You've been a big success, and I've loved seeing the work you do. But I wanted to ask you, could you tell me a little bit about what makes small cell lung cancer different from non-small cell lung cancer? And in your opinion, what do you think has changed with both of them over the last few decades?
Well, that's a great question. I would say that there have definitely been many more therapeutic advances in non-small cell lung cancer. When it comes to things like targeted therapy, um, all of the new FDA drug approvals, so many FDA drug approvals in the non-small cell realm. Small cell lung cancer, in stark contrast, has really lagged behind. Of course, we did see improvements in overall survival with immunotherapy and extensive stage small cell lung cancer back in 2019 and 2020, which led to new drug approvals, but at a much slower rate, of course, than what we see in non-small cell lung cancer. And we haven't really been able to personalize the therapy that we use for small cell as we have for non-small cell. For example, we don't have any targeted therapies. It's sort of one size fits all in terms of the treatment that we prescribe for patients with small cell lung cancer. And the question is, well, why is it this way? I would say in general, just thinking back to the biology of small cell lung cancer, we haven't had these vast tissue banks of small cell lung cancer biospecimens to really study the biology of small cell lung cancer because it really hasn't been a surgical disease. And many times for small cell patients, it's hard to get that tissue. So we haven't had as robust translational science developments in the small cell realm. And I think for those reasons, it's really lagged behind. But I think we're finally seeing more progress in small cell lung cancer. We're starting to see advances in drug development. And finally, our patients are having better treatment options. So it's a really exciting time for patients and for doctors that have treated small cell lung cancer. Because to be honest, it has been challenging. We all have had those patients that we have really tried to give hope to, but have had, such difficult disease courses and things like that. So it can be frustrating at times, but I think that things are changing.
Yeah, it's kind of funny. I remember asking that question to Mike Perry several years ago, but I think your answer is much better than his was at that time. Um, One of the things I really enjoyed this past spring was watching the updates coming out of ASCO. And one of the updates I kept seeing about, and I was really impressed with, was the results of the Adriatic study. I was wondering if you could tell us a little bit of the hypothesis that led to the Adriatic study. And also, I guess, what it meant for, the results and what it meant for patient care. I guess I'm kind of combining two questions at once there.
Uh, So the Caspian trial showed that the addition of durvalumab to chemotherapy improved overall survival for patients with extensive stage small cell lung cancer. So the idea of the Adriatic trial was to try to move that immunotherapy into earlier stages of small cell lung cancer, into the treatment of limited stage small cell lung cancer, trying to make a bigger impact, cure more patients. And so in this trial, patients received standard of care, concurrent or sequential chemoradiation. They then were able to receive PCI at the discretion of the investigator. And then they were registered for the study after completion of that chemoradiation and PCI, and then went on to receive either durvalumab, placebo, or durvalumab plus tremelimumab. The immunotherapy was continued for 2 years, and the results presented at ASCO showed that overall survival and progression-free survival were significantly improved. which again is very exciting. We've been treating small cell lung cancer limited stage the same way for many decades. So again, no advances in this space. And this is one of the first therapeutic advances for our small cell lung cancer patients that have limited stage curable disease. So it's a really exciting moment.
So one of the things that kind of interesting happened in my clinic with one of my patients. I think she finished chemo rads back in this past February. Abstract was presented at ASCO in May. In your opinion, and I know this may not be the easiest question, but are we allowed to retroactivate the study? And, how long after they finish chemo rads could we still start the 2 years of Infinzi?
That's a good question. Generally you'd want to start it typically within 6 weeks or so of completing the chemoradiation. I would, if somebody is in surveillance now and doing well after completing chemoradiation, 3 or 4 months ago, I would continue surveillance at this point. If you have a patient that is about to finish, I think that is a different scenario, and you could certainly think about whether or not you should do durvalumab. The FDA, I think, should be likely approving durvalumab very soon. They have to, of course, receive the data and review it and garner their approval. But, it could be given off-label right now since it's an approved drug. So I think for patients that are about to finish and in that range of, having completed chemoradiation and are within, 6 to 8 weeks, I think that those patients could be considered for immunotherapy. Longer than that, I would probably just continue surveillance because that's sort of already the track that you've taken so far. And of course, you would always be able to do immunotherapy at relapse if that happened.
So the key point is 6 weeks after we're done chemo rads to start the Imfinzi.
Yeah, and you want to make sure that they have resolution of any high-grade side effects from their treatment.
Okay. So in the year 2024, what do you consider to be the standard of care for limited stage small cell lung cancer as far as radiation therapy dose, the chemo, the drugs, all that stuff?
Sure, that's a great question. So I'm a believer in twice daily radiation for limited stage small cell lung cancer. So I think you give concurrent chemoradiation. I believe in BID. I think the trials have shown that once daily to 66 to 70 gray is not better than twice daily. So I would give twice daily radiation, 45 gray. I would typically give concurrent chemotherapy. I think it's okay also to start the radiation with the second cycle of chemo. Many times in practice, the patients are very symptomatic. It's helpful to give a cycle of chemo and then you can simulate and get a great radiation plan together and ready to give with that second cycle. I think that's a little bit easier, and that's what I tend to do in practice. I then would give twice daily radiation, 3 weeks, complete the 4 cycles of chemotherapy and radiation. I typically do give PCI unless it's a patient that has pre-existing neurologic problems like a prior stroke or multiple sclerosis or something like that. I think that the role of PCI is still sort of needs to be teased out in limited stage, and the Maverick trial certainly is going to answer that question for sure in the future. But then after PCI, I would give immunotherapy, durvalumab. I think that this is the new standard of care for patients with limited stage small cell lung cancer based on the really significant results from the Adriatic trial.
Okay. Is there any chance you think durvalumab could replace PCI? I know I'm asking a question that maybe I shouldn't ask, but I figured since, I have the opportunity, I would.
Yeah, I think that there is a possibility. I think we've seen signals that immunotherapy does have some efficacy when it comes to prevention of brain metastasis. Certainly, if you extrapolate from the Pacific trial, we saw less brain metastasis when durvalumab was given after chemo RT for non-small cell lung cancer. So I think we'll have to dig into the studies a little bit more and look at what the outcomes were for patients that did not receive PCI. Certainly, we know that PCI is morbid. If we can avoid it, then and not have a detriment to overall survival, then I would like to do that, of course, for my patients. But I think that we should have a better handle on that in the next few years.
So we talked about this being the year 2024. Let's pretend it's 2028 or 2030. What do you think the future of small cell lung cancer therapy is going to be? You mentioned Maverick. Is there any other particular studies you think we should be looking at?
I
Any
think that
questions any questions you think we should be answering?
I think people will be looking at adding on to the durvalumab to even improve survival and progression-free survival further. So are there any other drugs that could be combined with immunotherapy that could be effective? Certainly we have drugs like tarlatamab that are showing efficacy in extensive stage small cell lung cancer. So I think it's going to be about how do you combine immunotherapy with any other drugs that could, again, potentially yield better survival. So yes, I think the PCI question is a very important one. And then of course we have the dose escalation BID radiation that we've seen in Europe. There was also a trial at this ASTRO in 2023 looking at dose escalated twice daily radiation. So, those are other potential ways that we could make the chemoradiation part of the treatment more effective. We haven't seen that tested in sort of a North American population right now.
That's really exciting to hear about. I mean, I think it's going to be a great couple of years coming up for small cell. After years of no progress, I think Michael Perry would be very proud of seeing the progress over the last few years. I just want to say thank you, and I appreciate your time. I hope to see you at ASTRO or some other upcoming meetings. All right?
Awesome. Thank you so much.
Okay, stay safe.
You too.